Hi, I'm Gavin Giovannoni, and I'd like to thank the Karolinska Institute for inviting me to present at the Nobel Symposium on infectious mono as a pragmatic target for preventing multiple sclerosis. I do have a large number of disclosures, and I must say relevant to this presentation is that I am consulting for several pharmaceutical companies developing vaccines and treatment for multiple sclerosis. I wanted to say that there's been certain changes in my academic career. I'm in Snipers Alley. Some of you may be aware that about 4.5 years ago, I was involved in a very serious accident whilst out running, and I had a fractured cervical spine, pelvis, a head injury, and I was almost not here. And then I had a invasive melanoma diagnosed and excised 2 years ago. Thank goodness I haven't had any metastases, although I did have a scare about a year ago. And so Snipers Alley refers to the time of life between about 40 and 65, where people often get taken out by unplanned events. And I'm hoping to encourage young people in the audience to take up my hypothesis if I don't make it through Snipers Alley to do the research. I'm also describing a syndrome of going full circle in that I'm stopped seeing MS people with multiple sclerosis in clinic to focus on MS prevention, and I'm going back to what I did in medical school, is to manage pharyngitis, and I'll explain why. So I had an epiphany in 1999. I went to a meeting held by the UK MS Society in collaboration with the National MS Society in the US. It was held in Brighton, where we discussed various infectious causes of multiple sclerosis, and there were a large number of bacteria and viruses that were discussed. And I remember having an epiphany when Sven Haar, a person who had multiple sclerosis from Aarhus in Denmark, presented the Danish data linking infectious mono and EBV infection with multiple sclerosis. And I came away from that meeting saying Epstein-Barr virus has to be the cause of MS, and I've been making that case for the last 25 years. And it's good to see that at this meeting, a large number of people are now taking the EBV MS hypothesis seriously. What is interesting is that Sven Haar used this heterophile antibody assay, which is called the monospot, to diagnose IM. And we know that in the past, these heterophile antibodies are non-specific antibodies that tend to be induced by Epstein-Barr virus and are used to diagnose the condition. And I would also just urge people to make sure when they do discover autoantibodies in the context of Epstein-Barr virus infection and MS, that they must make sure they're not heterophile antibodies. They should probably sequence the genes that are responsible for making the antibody to see if they're high affinity antibodies that have gone through the germinal center in the B cell. I noticed at this meeting that there's been a lot of confusion around causation theory, so I thought I would just add a little section to my talk about why causation theory is so important. And I've put up this statement that EBV is necessary but insufficient for someone to develop MS. In other words, you have to have the virus to develop the disease. And I think this is a truism. Some might think this is a proposition that needs to be tested, but I think the epidemiology is overwhelmingly supportive of this. I did a Substack MS Selfie post prior to the meeting, and one of the commentators came back and said it's not just EBV that causes MS, there's lots of other things. And I'm not disagreeing with that, but because it's necessary, it's important. So it's remarkable how many people misunderstand the statement necessary but insufficient. If EBV is necessary, then preventing people being infected with Epstein-Barr virus will prevent them developing MS regardless of other factors. And I think it's that simple. It doesn't matter what the other factors are and how complicated the pathogenesis and the causation of MS is after you have EBV infection. If you take away the pivotal factor, everything else is irrelevant. And that's the hypothesis that we need to test. Anyway, to prove causation, there's a whole lot of criteria to go through. So Austin Bradford Hill's a very famous British statistician who discovered that smoking causes lung cancer with his colleague Richard Dole. And he put together, after the event, a set of criteria to prove that an environmental exposure like Epstein-Barr virus causes MS. And I personally think we've ticked all 8 out of 9 of these when it comes to EBV and MS. I know a lot of people say the strength of the association is relatively weak. That's not surprising because EBV is a very common exposure. 95, 96% of the population will eventually be infected with the virus. So it's a very common exposure, but very few people get MS. And when you have that scenario, common exposure but a rare event, the odds ratios or the risk of getting the disease can be low. The other criticism, it's not specific. So EBV is linked to many other diseases, and that's in many other autoimmune diseases. That doesn't worry me because if EBV triggers autoimmunity, you'd expect it to be associated with several autoimmune diseases. So it's not just MS, it's lupus and rheumatoid arthritis, etc. I'm not going to go through all these, so I would recommend that if you are interested in this, please read Bradford Hill's paper from 1966, or I wrote about this in 20 years ago in the Lancet Neurology, which is worth reading. I also want to remind you that causation is not a black and white, and doesn't happen suddenly like a light switch moment. Aha, eureka, this causes the disease. It often takes decades and sometimes centuries to prove that an infection causes the disease. So Theodor Bullroth, for example, he was a German surgeon that discovered streptococcus. It took about 100 years to show that streptococcus caused, for example, rheumatic fever. Robert Koch, who discovered the bacterium that causes tuberculosis, took about 15 years to convince the wider community, his colleagues, that TB, Mycobacterium tuberculosis, caused tuberculosis. And to do that, he actually formulated Koch's postulates. Similarly, Richard Dole and Austin Bradford Hill, they discovered that cigarette smoking, their first report came out in 51, their big study in 55, and then it took about another 50 years for example, finally for the tobacco industry to capitulate and eventually agree that smoking caused lung cancer. Marshall and Warren, Australian investigators, proving Helicobacter bacterium causes peptic ulcer disease. Montagnier and Sanusi, HIV and AIDS. That took about 15 years to convince the world. And then Zerhausen, who showed that HPV, a viral infection, was linked to cause cervical cancer. That took about 30 years to prove. So just to say that when somebody comes out with a statement that this virus, EBV, causes MS, it's going to take a while. And the reason why it is because it's a social phenomenon. And Everett Rogers, a social scientist that worked in the 60s, showed that the adoption of an idea or a fact or an innovation takes time. And he proposed the adoption curve, that people who innovate come up with the idea or the concept, they're early adopters, majority adopters, late adopters, and there'll all be a group of people who never accept it. We call those laggards. What we do know is once the adoption curve hits around about 30%, it often ramps up rapidly. And at the Nobel meeting, when David Hafler actually asked the audience, how many of you think EBV is the cause of MS? And there were about 5 or 6 hands that went up. So I do think we're around down the bottom here in the early adoption phase rather than at the majority adoption phase. That doesn't matter because it will take time. For people in the audience who want to read more about causation, I would recommend reading the Fredericks and Relman paper about modifying the Koch's postulates for infectious diseases. I would urge people to read the Bradford Hill paper in the context of cigarette smoking causing lung cancer. And I love this book by Alfred Evans on causation and diseases because it goes through several case studies and gives you examples how long it took and why it took so long for. Now, this is the model of Roberto Scheria, supported by his epidemiological data, just showing you that if you get late symptomatic EBV infection, which we call infectious mononucleosis or glandular fever, you're at very high risk getting the disease. And importantly, people who are EBV negative are protected from getting MS. The risk of getting the disease is almost zero. And the hypothesis is very simple. If we stop people getting infectious mono, will we reduce the risk? And if we stop people getting Epstein-Barr virus, will we prevent the disease completely? And those are the two hypotheses I'm going to talk about in this meeting. So the first experiment is vaccination. It's very simple. I've put up the domino model of causation. As you can see, EBV is a late exposure. You may have the genes that predispose you to the disease. You might be born in the right month. You have low vitamin D. You may have childhood obesity. You may be more, have female sex. So these are all risk factors for MS. So that when you get Epstein-Barr virus, it triggers the cascade. It leads to multiple sclerosis. And the theory is if you can vaccinate people and stop them getting EBV, you'll remove these dominoes and you'll stop the dominoes falling and you'll prevent the disease. And this is an hypothesis that's going to be tested. This is just showing you an adaptation of the Sclerosis model, that if we had a sterilizing vaccine and stop people getting infected, will we reduce the incidence dramatically by more than 90%? Not everybody will respond to the vaccine. If it's non-sterilizing, in other words, it prevents you getting infectious mono, but not wild type, it may reduce it down to what we call asymptomatic seroconversion. This is the hypothesis that's going to be tested, and I've written about this in a recent commentary in the MZAR journal. The good news is the EBV vaccine gold rush. There are many companies now testing EBV vaccines, some further ahead than others. So there are big phase 2 studies about to start, and hopefully we'll be able to get into a phase 3 study. Now, the big debate about this is how we design these studies, which populations we do, and I haven't got time to go through it today, but I'd urge you to read these 4 papers that I've been involved in, which goes through the theory and the type of vaccine studies that need to be designed. I mean, the big issue is, do we go for high-risk people, in other words, people who are high risk of getting multiple sclerosis, or do we do a population-based study? I'm in the camp that says population-based studies, and I think high-risk studies are really not feasible. You know, when you risk profile individuals, even if you do polygenic risk scores, the area under the curve of a ROC analysis is less than 0.8. So therefore, it's not good enough, in my opinion, to select. Even if you just go for first and second degree relatives, there are issues with that. So this is first and second degree relatives of people with MS, so their children or siblings. And the majority of people who are at high risk of developing MS don't develop the. And similarly, most people who develop MS are not at high risk of developing MS. So if you just go for high risk people, you're going to miss out on the majority of people. And if you go for people with positive family histories, there's only 1 in 7 people with multiple sclerosis have a family history of MS. So going for high risk actually excludes a large proportion of the people who are going to develop MS that are not related to risk or family history. The other thing is, we've done a survey recently, and parents are very reluctant to expose infants, because you have to go for infants when you want to get them vaccinated before they get exposed to the virus. People are worried about new vaccines, and so it's very difficult to be able to do an infant study. And so this is why we want to target adolescents. And by the time people get to 12 to 13 years of age, you know, more than 60% are EBV positive. In addition, there's a large lag time from EBV exposure to disease onset of about 8 years. So you can imagine the numbers of people you will need to make this study feasible in a short period of time. And similarly, the incidence of MS is relatively low below the age of 20. So you're going to have to wait a long time for the study to report out. And then what about other EBV-associated diseases? So if you just focus on MS and only do a trial on MS prevention, you're going to miss out on the other diseases. So this is why when you do the power calculations for a primary MS prevention vaccine study in high-risk adolescents, it's just not feasible. And I go through that. I go through that in much more detail in this commentary. So I've proposed, and I'm not the only one, that we target infectious mononucleosis, the main risk factor for developing MS, as the primary outcome in trials and the indication for the vaccine. Now, when I was in medical school, I was told that EBV-related infectious mono was a benign disease, self-limiting, and you got better, but it's not benign. It's a complete, dogmatic statement in the medical textbook that's incorrect. A significant proportion of people who get infectious mono are really sick. They get post-viral fatigue. They have to take time off school or university. This is a big impact on the military training, for example. And there's a death rate associated with infectious mono. It's usually from hepatitis or ruptured spleen. And there's a significant number of people who have to get admitted to hospital because of severe pharyngitis with inability to swallow, for example. And sometimes the swelling in the tonsils can be so bad that they're breathing problems. And then there's also all the economic arguments. So I don't personally think it's a pleasant illness to have, and so we should prevent infectious mononucleosis. And by doing that, we should then be able to potentially delay the complications of IM. So, you know, about 1 in 10 people with chronic fatigue syndrome have a history of IM. There's multiple sclerosis and all the other autoimmune diseases associated with it. And then there are all the cancers that EBV causes. So 1 to 2% of human cancers are due to EBV. And if you prevent infectious mono or prevent EBV infection, you may be able to prevent the cancers from developing. These are Hodgkin's, Burkitt's, and other B-cell lymphomas, nasopharyngeal carcinoma, gastric carcinoma, and there's quite a few other carcinomas linked to, or malignancies linked to EBV. And then obviously in immunocompromised patients, there's the complications of EBV reactivation with chronic IM, post-transplant lymphoproliferative diseases, hairy-leukoplakia, and a few others. So if you don't get infected with the virus, then when you do have to go into a situation where you're immunocompromised, you may be able to see that these don't occur anymore. So the hypothesis is very simple. If you EBV vaccine prevent IM, then you will prevent whatever happens during IM that leads to Hodgkin's disease and multiple sclerosis. I just want to point out that the lag phase from IM to Hodgkin's disease is about 3.5 years. So the first disease to report out won't be MS. And so the proposal is very simple, is to get a vaccine license at a population level to prevent IM, and then use population registries or health administrative data to see if the people who have been vaccinated have a reduced incidence of a basket number of diseases linked to EBV, which includes multiple sclerosis here in orange. And so this is the proposal in terms of primary prevention of EBV using a vaccine. The second experiment is treating IM, you know, developing a therapy for infectious mononucleosis. And I want to reason here by analogy. And I'm going to go back to my medical school days when I was a medical student. I'm having problems with my pointer. There we go. So I just want to say that I had the most inspiring lecturer when I was in third year medical student, a doctor, now Professor Stephen Miller, and he was a streptococcus expert. Actually, he discovered his own streptococcus. It's named after him. It's a group of bacteria called Strep milleri, and it causes infections usually after surgery. But he inspired us with his lectures and his enthusiasm for his subject. And this is the little beast. This is streptococcus. And when you actually grow it in the laboratory, it's got a character. This is called the blood agar. So this is made from blood. And you get this characteristic hemolysis pattern that recognizes the bacteria based on a protein that it produces that lyses red blood cell over. And this is what a strep pharyngitis or tonsillitis looks like. Just to say to you that of all the infectious diseases we know, this is the most potent trigger of autoimmunity. Obviously, the one that's most obviously known is rheumatic heart disease. We've also seen in Sydenham's career, and there are post-streptococcal glomerulonephritis, there's skin, arthritis, many other autoimmune diseases triggered by it. So this is actually a case of Sydenham's career. I'm just going to show you what it looks like. I don't know why it won't work. Let's see if it runs. There we go. Doesn't seem to want to run. I'm sorry about this. Anyway, what happens is these people get these abnormal writhing movements due to an antibody that affects the way the brain functions. And actually, there's lots of evidence that in a particular part of the brain called the basal ganglia, you get inflammation due to an autoimmune disease. The Sydenham's career was described by Thomas Sydenham, in 86. Oh yeah, it's running now. I can just show you what synonyms. This is a little kid in India.
क्या परेशानी है तुम्हारी?
And you can see the abnormal movements occurring.
सिर में भी पीड़ात है? स्कूल जाते हो?
4 महीने
नहीं गए 4 महीने से? क्यों बेटा?
Just to say to you that Sydenham's career was called St. Vitus dance in the past, and there were epidemics, and it was very common throughout the world. And I just want to point out that I trained in South Africa, and you can see that the burden of streptococcal infection is still global, but it's particularly a problem in sub-Saharan Africa, and tragically, Sydenham's career and rheumatic fever, glomerulonephritis, and all the other post-streptococcal autoimmune diseases are still very common in sub-Saharan Africa. When I was a fifth-year medical student, I had the opportunity of doing clinics. We had a clinic in Hillbrow, a poor part of Johannesburg. We used to do a thing called the Twilight Clinic on a Tuesday and Thursday evening. We used to run it for 2 hours from 5 o'clock to 7 o'clock, and I was a medical student. We were meant to be supervised, but we were actually just learning how to be general practitioners. And I remember on one of my first clinics in fifth year medicine, seeing a 12 to 14-year-old homeless street child, a little black boy, as they were all solvent addicted, glue sniffers, and he had obvious career. And when I examined him, he had evidence of a heart murmur, he had the nodules, and I thought he had rheumatic fever. We took him to the local hospital after the clinic. He was admitted, and I went back to see him about 2 weeks later, and he was on the pediatric ward being treated for acute rheumatic fever. And this case sticks in my mind because, you know, the question you've got to ask in 1986 in a high-income country like South Africa, you know, how can you have a homeless kid, you know, an orphan, developing a disease that's essentially a disease of the past, and it's, you know, this particular boy could be called Oliver Twist because this is like Victorian London, although this is modern South Africa, and this is a cartoon of Oliver Twist, a picture of Oliver Twist asking for some more food. And as you know, he was born in a workhouse, was orphan, and lived in 1830s London, where Sydenham's career was likely to be very, very common. Now you have to ask yourself the question is, why do we see rheumatic fever and Sydenham's career still in South Africa? And you've got to remember that South Africa is a country of two halves, the haves and have not. And when I grew up in South Africa, I grew up as a privileged white in an apartheid country where we had access to high income, good healthcare services, and the black population of South Africa didn't. I just want to point out that all authoritarian political systems eventually come to an end. And as you know, in 1993, there was a transition from the nationalist apartheid government of South Africa under F.W. de Klerk, and the ANC won the general election in 1994. But to recognize the remarkable transition of South Africa, the Norwegian Nobel Committee gave the Nobel Peace Prize to Nelson Mandela and F.W. de Klerk. What I'd like to point out that political systems come to an end, yes, but it does take inspired leadership. And anybody who knows about the history of the ending of apartheid will appreciate that it was two remarkable people that made it happen. When it comes to the Nobel Committee in Sweden, I'd just like to thank the Swedish Academy for at least acknowledging two anti-apartheid activists, writers, Nadine Gordimer and J.M. Coetzee. Both of these individuals wrote incredible literature opposing or highlighting the tragedy of apartheid. J.M. Coetzee is still alive. He's probably one of the most celebrated, or at least awarded, living writers. He's won the Nobel Prize for Literature. He's won the Booker Prize twice and numerous other awards. And his books are quite compelling. So I would urge you to read them if you are interested in the impact of apartheid on individuals' lives. The one that got away, in my opinion, is Alan Paton. So Alan Paton's book, Cry Thy Beloved Country, was published in 1948. It was banned. So when I was a child, I wasn't meant to read it. But I had a very liberal aunt, my mum's cousin, who'd come from England. And she slipped me a first edition copy of the book when I was 12. She said to me, Gavin, I want you to read this book, but don't tell your mother that I gave it to you. And I still have that copy. It's a first edition, and probably worth some money, actually, of Cry Thy Beloved Country. But Alan Paton was nominated for the Nobel Prize for Literature in 1972, but didn't win it. And I personally think that Cry Thy Beloved Country is probably the best representation of protest literature, highlighting the impact of apartheid. You've got to appreciate that the book was written prior to South Africa leaving the Commonwealth and becoming a republic. So this was actually when we were still part of the Commonwealth. And if you go back in the history of apartheid, it was not necessarily put in place by the Afrikaner white community. That's the common myth. You know, all the structures and laws were in place from the British Empire. Anyway, I did then move to London to do a PhD in 1993, and I ended up where Dickens lived, in Dickensian London. So I actually spent 3 years living on Mecklenburgh Square in a place called London Goodenough House. And I did my PhD around the corner at the Institute of Neurology, which is linked to the National Hospital in Queen Square. There's Dickens. He lived in Darty Street, very, very close. So this was where Dickens lived. He used to work in Gray's Inn, and he used to often after Gray's Inn apparently walk down Lamb's Conduit Street, because there's a little pub there called the Lamb, and on the wall it says this was Charles Dickens' local pub. But Charles Dickens would have seen a lot of post-strep autoimmunity, and he was a great observer. And if you've read David Copperfield, Uriah Heep probably had Sydenham's career. He had a way of writhing when he wanted to express enthusiasm, which was very ugly. And I suspect what Charles Dickens was describing was somebody with a post-streptococcal autoimmune disease. Around the corner from Queen Square is Great Ormond Street. This is the new hospital. The old hospital used to be on the corner. So this is a picture of the original Great Ormond Street Hospital. That's Great Ormond Street, and this is actually Queen Square, and next door is the National Hospital for Neurology and Neurosurgery. So when I was at Queen Square, Russell Dale, my PhD student, and David Martino, one of the Italian neurologists who came on a Marie Curie fellowship, went back into the notes from Great Ormond Street from 1852 to 1936 and analyzed the records and showed that Sydenham's career was an incredibly common cause. And you can see how many admissions on average were occurring in January. And there was a seasonal distribution, which we know about streptococcus. So you get much higher incidences of the disease in winter than the summer months. And the dark bars are rheumatism, which is rheumatic fever. So at any one time in Great Ormond Street, about on average 40% of the inpatients had either Sydenham's career or rheumatic fever. This is how common post-streptococcal autoimmunity was in Dickensian London. And the link between streptococcal infection and autoimmune disease is now incredibly well established. So you get the exposure, you get exposed to the bacteria, you develop the pharyngitis. It can also cause skin infections, impetigo, but most of the cases have pharyngitis or tonsillitis, and about 2 to 6 weeks later, you develop inflammation, which we think is autoimmune in the heart, or kidney or skin or whatever. What we do know now is if you give antibiotics to treat the infection, you prevent the autoimmune disease. So treating the infection prevents the autoimmune disease. And this has been well studied. This is just showing you the mortality from rheumatic fever in the United States. So there's the curve. And when you bring in antibiotics, sulfonamides or penicillin, you can see the incidence tending towards zero. A remarkable success. And this is Canadian data just showing you that despite penicillin coming onto the market, the incidence of infections remained the same, but the incidence of rheumatic fever plummeted. Okay. This didn't require a randomized control trial. So an antibiotic came out, you treated the tonsillitis, and you prevent rheumatic fever. And that's what we call primary prevention. Unfortunately, there have been attempts to develop a vaccine to prevent streptococcal infection. It hasn't been successful yet. It may be in the future. Now, once you've had your attack, if you give chronic antibiotic therapy, so persistent therapy, you therefore prevent further infections, and you prevent the relapses that occur, and you prevent the end organ damage to the heart or the chronic progressive rheumatic heart disease that you see when you get scarring of the valves. This is a post-mortem picture of a rheumatic heart with mitral stenosis. This is a fibrosed, narrowed mitral valve. You can see how thick the muscle is on the heart because it had to work extra hard. So secondary prevention works because recurrent infection drives the autoimmunity to have recurrent events. So this is kind of very analogous to multiple sclerosis. And this is one of the reasons why we may want to use antivirals to prevent recurrent relapses of infection with Epstein-Barr virus. For the immunologists in the audience, just to say that when you go into the literature, there's lots of data that strep triggers autoimmune heart disease via molecular mimicry. In other words, proteins that streptococcus produces triggers an immune reaction to proteins in the heart. There's also these things called superantigens. There's also exotoxins that are also linked to the autoimmunity. And just to say that certain strains cause different autoimmune diseases. So a particular strain will cause kidney disease, whereas another strain will cause heart disease. And this may be relevant to EBV causing MS. Now, I don't personally know exactly how EBV causes MS. The two competing hypotheses is it's hit and run. So one, you have the infection that triggers the autoimmunity, and then the virus is irrelevant. I favor the driver hypothesis. You get persistent infection, which is latent infection, and this cycles into lytic, and you get this latent lytic cycling that drives the disease. Against the molecular mimicry hypothesis is the lag. So when you get exposed to EBV and get IM, it takes about 8 years on average before you have your first attack of MS. In other diseases where molecular mimicry has been accepted, like strep and rheumatic fever, or Campylobacter and Guillain-Barré syndrome, or flu vaccine and narcolepsy, the lag phase is much shorter, 2 to 6 weeks. Okay, so this is an argument against molecular mimicry driving. But I must say, we don't really know where MS begins. We do know that people who have their first clinical event, the majority of them will likely have had the disease for at least 5 or more years, either with prodromal symptoms or even asymptomatic radiologically isolated syndrome. And we know from Alberto Scherier's study that after EBV infection, some people have raised neurofilament levels, implying damage to the nervous system. So MS actually may occur a lot earlier. It just takes much longer for the disease to manifest. And so it's going to be critical for us to start studying people with IM again, to see what happens in the first few weeks or months afterwards, to see if we can pick up any markers of early MS. And my hypothesis, my prediction will be that MS starts quite soon after infectious mononucleosis, but we'll see. I have written extensively about the latent lytic cycling model, and why people with multiple sclerosis have an aberrant immune response to the virus. And I'm not going to go through that. And I would urge you to read my commentary on what the T-cell responses are telling us about the importance of multiple sclerosis. I wrote an editorial commentary earlier this year around the T-cell responses, T-cell response data from Germany. And I've just been involved in quite a large paper where we make the case for targeting both latent and lytic EBV infection as a treatment for multiple sclerosis to prevent latent lytic cycling. I haven't got time to go through this in detail, but my overall conclusion is we need a CNS penetrant drug that targets both latent and lytic infection. And so the hypothesis, again, like the vaccine hypothesis, is if we treat IM with an antiviral, we will stop the immune dysregulation that occurs as part of acute IM, and we'll prevent all the downstream events. And that's directly analogous to the streptococcal tonsillitis pharyngitis causing rheumatic fever and other autoimmune diseases. If we treat IM, reduce viral loads, stop the aberrant immune response, we will prevent or reduce the risk of developing multiple sclerosis. And so this is, again, the hypothesis is, can we reduce the incidence from about 1 in 100? That's what the lifetime prevalence of MS is in people who've had infectious mono. Could we reduce that down to, say, 1 in 800? In other words, the prevalence in people that are asymptomatic EBV carriers. We don't know until we develop a therapy. And again, if we develop a treatment, we may be also able to show an impact on immunophenotyping. So people who have infectious mononucleosis, they have dysregulated immunity that you can pick up. They have abnormal CD8 T cell responses, they have abnormal NK cell responses, and their antibody responses are different to people who seroconvert asymptomatically to the virus. So we may be able to actually get an early indication that if we develop an antiviral and stop the immune changes, we may predict earlier that it will have an impact on MS incidence. And using the domino model again, simply get exposed to the virus. This time you're coming in later than with a vaccine. So you're coming in after you've got the virus. It'll stop the downstream events and prevent the disease from developing in the long term. And again, if we can get a licensed therapy, then we could do population-based studies where you look at people who have been treated or not treated and see if the incidence of a basket number of diseases is reduced. And this is why we need to have very good databases. So certain countries, particularly the Nordic countries, in Sweden in particular, who have incredibly good incidence databases of MS. This is the Scottish database. You can see a rising prevalence and incidence of the disease. And and the whole idea was when you bring in a treatment for IM, will you see this curve go down? And that's what I would predict based on the analogy with streptococcal sore throats and in rheumatic fever. So yes, I'm hopefully going to survive Sniper's Alley. I'm quite coincident with this meeting. I'm about to have my second primary melanoma excised from my back. Well, I've had it excised already, but I've got to go for a wide excision next week. So I definitely in Sniper's Alley. And just to say that I have come full circle. I went from being a medical student to training as a neurologist, becoming an MS expert. And I made the decision because of the overwhelming amount of work I was having to do as a neurologist to stop seeing patients with MS and go back to being a medical student and becoming an infectious disease expert and working in collaboration with my colleagues in A&E to try and sort out the diagnostic and management pathway of patients with both infectious mononucleosis or streptococcal infection. And I'm very fortunate that at this meeting to have had discussions with numerous people. Scott Montgomery, epidemiologist from Sweden, who's going to help me make the economic argument for treating IM. Lars Fugger from Oxford, and Olivia from Stockholm, two immunologists are going to help me with some of the immunological studies tied to IM. And I've got a question mark here. So if anybody else wants to get involved, I've done a lot of thinking and work on this already. If they want to set up IM services or prevention strategies in their country, they can talk to me and have all the documents I've prepared for this. I think the point I'm trying to make is it's not going to be one group or one country to prevent MS. It's going to have to be an international effort, and the more people getting involved in this hypothesis, the better. And at the same time, I'd like to call to arms. It's quite tragic, but we've got an epidemic of measles occurring right now in London and the UK, simply because of the anti-vaccine lobby and people not vaccinating their kids. We have a lot of vaccine resistance to MMR, and this is not only in the UK, this is internationally, and we have to push back on it. And I would urge you to read this frightening editorial in Nature Medicine from April of this year about combating vaccine revisionism. There's a whole movement in the United States to question the safety and efficacy of the MMR vaccine, which is quite tragic. It's not only MMR, there's been a pushback by Kennedy around the COVID-19 vaccine for young children, and the CDC is caught between this political battle that's occurring around vaccines. my opinion is, these vaccines are very safe. They reduce the incidence of some life-threatening diseases, plus the complications that can occur to the life-threatening diseases. And why should we, march backwards in time away from these incredibly effective innovations that have been shown to work? Anyway, if we don't push back on vaccine hesitancy, who's going to take an EBV vaccine when it does get licensed? So this has implications for MS prevention, because I personally think an EBV vaccine to prevent you getting infected with the virus or reduce the chances of getting infectious mono will reduce the incidence or prevent MS. And so if the vaccine comes out, could you imagine what a tragedy it is if the uptake of the vaccine is low and the incidence of MS doesn't drop? So this has to be our priority, is to get the vaccine into the population and to get people to get vaccinated. And I just want to say that I was completely horrified that despite us knowing about streptococcal infection and rheumatic fever and other autoimmune diseases, this is still an enormous problem. So there was a review done, even though it was done in 2005, nothing's changed, that they estimated that there were over 700 million cases annually and 500,000 deaths due to streptococcal infection. 616 million cases of pharyngitis and about 110 million of the skin infection, pyoderma impetigo. And when it comes to the complications, they estimate there are 18 million existing cases of severe streptococcal disease. This is the autoimmune and other consequences, with about 1.8 million new cases each year and about another 500,000 deaths. So when you actually put the deaths from acute infection and the deaths from the complications in place, there are over 1 million deaths globally as a consequence of group A beta hemolytic streptococcal infection. So this is quite frightening, considering we have very effective therapies to treat streptococcal infection. Anyway, to conclude then, I just want to say that EBV is the cause of MS and possibly several other autoimmune diseases and several human cancers. Acute EBV infection, or IM, is not a benign disease. It's frequently misdiagnosed. I've got data for this. It's inappropriately treated with antibiotics because A&E doctors and general practitioners just give antibiotics to cover strep without finding out if it could be IM. It has a significant socioeconomic burden, and I think high healthcare costs and loss of productivity, particularly in young people. I personally think we need to update the diagnostic criteria for IM, including PCR to diagnose the virus. And we definitely need antiviral treatments to reduce the severity of the disease. So we need a public health policy for preventing and treating IM. We need more data for making the case for a global population-based vaccine, and we need the antiviral trials to continue in MS. This has to be an international initiative. We've got to make the case for population IM vaccine programs. We need to propose study designs, which we've done in many papers, with power calculations and describing the logistics of getting these trials done. We also need to not ignore low, middle income and low income countries, because nasopharyngeal carcinoma and Burkitt's lymphoma, which occur in Southeast Asia and Africa respectively, are enormous problems in those countries. And we also have to partner with the pharmaceutical companies, so we aligned. The vaccines are going to have to be developed and tested by the big pharma. We just don't have the resources in academia. And we'd like the pharmaceutical industry, or I would like the pharmaceutical industry, to develop new antivirals to treat IM. And obviously, we need a public engagement campaign. We need to make the world aware that MS is a preventable disease. There's a target on how to prevent it. And we also have to counteract vaccine hesitancy. So I'd like to stop there and take questions, and just to remind you that EBV is necessary but insufficient for someone to develop MS. I think this is a truism. And as old Schopenhauer said, truth passes through 3 stages. It's first ridiculed, it's then violently opposed, and all of a sudden becomes accepted as self-evident. And so let's hope this happens with this truism that EBV is the cause of MS it's necessary but insufficient. So in other words, not everybody who has EBV will develop MS. A small number will. So there are other factors that at play, but you remove EBV and those other factors are irrelevant. And that's the hypothesis that we have to test. I'd like to thank these people and organizations for funding. And this is the group of individuals that has helped me so far on my journey from 1999 until 2025, investigating EBV as a cause of MS. And I'll stop there and take questions. Thank you very much.